Um, so um, we'll cover a little bit about what haematology is, which is my specialty. We'll talk about what a career in haematology involves, and we'll go through a few cases to give you a flavour of kind of what I do day to day. And then at the end, I'll talk a bit more about my journey in medicine and kind of how I got into what I did before to get into medical school and where I've worked and that sort of thing. And then we'll have plenty of time at the end for questions as well. Um, so in terms of just a general flavour of what haematologists do, so I am more a malignant haematologist, so I generally work in the cancer space. So the cancers that we mainly deal with in haematology are leukemia, lymphoma, and myeloma, which essentially are the kind of blood cancers, bone marrow cancers. Any other cancers are kind of what we call solid tumors, which would be more like lung cancer or pancreatic cancer, and they would be managed under oncology rather than haematology. But within haematology, we don't only train in cancer. So we also train in thrombosis, which is blood clotting. So if someone gets a deep vein thrombosis, for example, we train in bleeding disorders such as haemophilia, hemoglobinopathy, which is mainly sickle cell disease and thalassemia, autoimmune hematology, which is things like ITP and autoimmune hemolytic anemia. ITP being essentially where your immune system starts destroying your platelets, which are something in your blood that helps your blood to form blood clots. And then some hematologists also work in transplantation. So that's bone marrow transplants as opposed to solid organ transplants. And the other thing in haematology is there is the potential either to specialize or not. So some haematologists working in district general hospitals will do a bit of everything. It tends to be only in the big tertiary centres, the teaching hospitals, where they sort of look after transplant patients, and often acute leukemias as well won't be managed in the district general hospitals. But other than that, a lot of haematologists and district generals will cover a bit of everything. They might see some patients with blood clots, some patients with lymphoma, whereas in sort of larger teaching hospitals, it tends to be a bit more specialist, and it tends to be you may only do, one of the cancers as opposed to all of them, or you may do sort of cancer as a whole. It just depends. So if we go through a couple of cases, just to give you an idea of what we do. So this is kind of a standard patient that we might see. So if we have a 21-year-old university student, I should say 3-week history of bone pain usually. So there's no trauma history. So if anyone comes in with bone pain, you want to sort of say, have they hurt themselves? Have they fallen over? But there's no trauma history here. So it's bone pain of unclear cause. And this student has been coming to A&E 3 times. They've been to the GP multiple times, and each time they've kind of been fubbed off, because they're young. It's probably just nothing. You've probably pulled a muscle, and they get given different painkillers. And each time they go back, someone gave them paracetamol. At some point, they got an X-ray, and then they got to codeine and tramadol, which are stronger painkillers. Generally, if patients come back again and again and again, if people come back to the doctor, then often there is something going on and it has to be taken more seriously. So this patient eventually in A&E was seen and examined by a doctor, and they were found to have these bruises over them. So they were ordered for some blood tests. An FBC stands for a full blood count, which is essentially a check of whether you're anemic, your white blood cells, and your platelets. You do a renal and liver function test, so your kidney and liver, and a clotting screen. So if someone has bruising, you might want to know if their blood's clotting normally, so you do a coagulation screen. And then when everything came back, so just a few of their results, you can see there that the hemoglobin is very low at 53. It should be over 135 for a male. So very, very low. To give you a bit of sort of orientation with that, it tends to be if a patient is under 70 or sometimes 80, that's when we would give a blood transfusion. So 53 is really quite low. The white blood counts is a bit high, and the platelets are also low. So when that happens, you get a very abnormal blood count. They'll call the hematologist, and they'll say to the hematologist, the lab will automatically make a blood film, which essentially is putting the blood on the slide so that the hematologist can look at it under a microscope. So as the hematologist here, you'll go to the lab, you'll look under the microscope. You can see the top right picture is essentially the cells you'll see. All these kind of purple cells are white blood cells. What you should see is what's on the bottom right picture, which is not necessarily all of those things at once, but they're different types of normal white blood cell that you would see in the blood. Whereas you can see the top right, they all kind of look the same. When everything all looks the same, it's often cancerous. And this is concerning for leukemia. So these, are leukemia cells. That's what they look like. So all blood cells are made inside the bone marrow. So the next thing the hematologist will do is obviously go and check on the patient, see how they are, see if anything urgent's needed. But to kind of make, whilst you haven't made the diagnosis on the blood, you need more information, which you can only get from the bone marrow. So it'll be the hematologist that comes and does the bone marrow biopsy. So you'll stick a needle in the back of someone's hip, as you can see here, using local anesthetic, and you suck out the bone marrow from the middle of the bone. And the two slides with what looks like blood on them in the middle that's actually bone marrow. So it does kind of look like blood, but it's got what we call particles in it, which are those kind of blobs that you can see on the slide, and those wouldn't be in blood. And then we look at those under the microscope and we send off some special tests, and that will tell us exactly what type of leukemia it is. And in this age, we get, for example, you can do a genetic test, and if that type of leukemia has a specific gene mutation, there may be a drug that is available that targets only that type of leukemia. So it's quite important because the treatment will now vary depending on the exact type of leukemia, whereas 15, 20 years ago, you just had standard chemotherapy and it was kind of more one size fits all. You didn't have access to all of this stuff. So things are moving quite rapidly. So the management of this patient, so they would have been admitted. Acute leukemia is something that is obviously any cancer diagnosis is shocking for patients, but I think acute leukemia is probably one of the worst, not because it's got the worst outcomes, but because of the immediate impact. So most patients, if you're diagnosed with cancer, you will still go home afterwards. You'll still be with your family. You'll have time to adjust to this. With leukemia, you have to start the treatment straight away when it's acute leukemia. Chronic's a bit different. But acute leukemia tends to be, if we don't do something sort of in the next couple of days, you can die very quickly. So you have to admit them and they have to start the chemotherapy in a hospital. And it's such intense chemotherapy that the patient generally has to be in hospital for the whole time, which will be about 4 weeks usually before they have a break of a week or two at home. And then they'll come back and go again. And patients often have, 3 or 4 months of chemotherapy or longer. So the life impact, is massive. You'll see patients, it could be like a 42-year-old on his way home, hadn't been feeling well, so eventually just decides to go to A&E, and essentially once he's in A&E, he's not going home for a month. And so it's quite shocking and it's quite difficult. It's quite lonely when patients kind of put in a room and given chemotherapy, so their immune system's down, they can't interact with people in the same way. So you need certainly a lot of psychological support. So as the hematologist, we've kind of discussed all this, but we'll see the patient, we'll look under the microscope, we'll do the bone marrow biopsy, we'll look at that under the microscope, we'll obviously break the bad news to the patient, we'll talk to them about the chemotherapy, we'll prescribe it, and then we look after them in the kind of post-chemotherapy period. So it's one of the only specialties where you have some lab work and also some clinical. Whereas, there's other specialties like histopathology where you're only in the lab and you don't see patients. And obviously there's other specialties where you only see patients. But this is, I think, really one of the only ones where you do a bit of both. The other one being kind of micro and ID when people in infections, they do a bit of lab and a bit of clinical as well. So the MDT, so the multidisciplinary team is huge here. So you'll have specialist nurses, which is what CNS stands for, dietitians, psychologists, physio and occupational therapists, lots of other people involved in the patient's care. Just while we're on this, because CAR T therapy is a treatment now for leukemia, but also for lymphoma and myeloma. And it's quite topical in the press. You may have seen articles, certainly when you get to the point where you're going for interviews and you're looking more carefully at what's been going on in the press, CAR T is certainly something that will come up very easily. So this is essentially a treatment where you collect the patient's T cells, so T lymphocytes, and you essentially put the patient on a machine that filters out their T lymphocytes so that you've got them in a bag at the end of it, essentially. And you genetically modify these T cells using a chimeric antigen receptor. And what you do is you put a specific protein on the surface of that patient's T cells that will target their cancer. And then you kind of grow the cells, and when they're ready, you put them back into the patient, and those T cells will now have something that they can use to bind to the cancer and destroy it that didn't have before. So it's kind of a very new targeted treatment. for hematological cancers. And there's a really good documentary that was on a couple of years ago on BBC iPlayer that's probably still there about the first CAR T patients. That was really interesting, and that might be something to look up if you're interested. So moving on to case 2 then. So this is something else that we see commonly, which is myeloma. So these patients tend to come in with what we call CRAB symptoms. So CRAB is the way that people remember it because it's easier to remember. So high calcium is the C, renal or kidneys is the R, anemia is the A, and B is bone problems. So if you have a patient who comes to any with a sort of combination of those things, although they could present to the clinic as well, then we're thinking about myeloma. So the same as leukemia, it's going to be a cancer that starts inside the bone marrow. So the patient's going to need a bone marrow biopsy for you to find out the cause. The cells are going to look different to the leukemia cells. The genetic tests, the different tests we do are going to come back differently, and the treatment's different. It's still a sort of chemotherapy, but it's a different prognosis, different age group. So the leukemia patients can be any age, but it can be quite young, whereas myeloma, I did once see a 17-year-old with myeloma, but generally it's much more older patients. I mean, we've got hundreds of patients in our myeloma clinic at work, and of the ones on chemotherapy, I think I've got 2 in their 40s, and everyone else is older than that. So these are plasma cells, which are the cause of myeloma. So normal plasma cells make antibodies and are a useful part of the immune system, but when they become cancerous, it can form a cancer called myeloma. You've got an image there of an MRI showing how myeloma can essentially cause erosion of the bone and can actually come out the bone and press on the spinal cord. So myeloma patients can present with compression of the spinal cord. And again, they get chemotherapy, sometimes radiotherapy. And the stem cell transplant in myeloma is slightly different. We do something called an autologous stem cell transplant. So when we talk about transplant in leukemia, we're talking about a transplant from someone else. Whereas when we talk about it in myeloma, we're talking about a transplant using your own cells. And the logic there is that sometimes, if we talk about leukemia first, sometimes when a patient's had chemotherapy, despite the chemotherapy getting rid of the leukemia initially, you may find that that's not good enough and the leukemia is going to come back. So the only way that you can get rid of the leukemia for good may be to give the patient such a big dose of chemotherapy that it wipes out their immune system forever. But obviously, they'll then have no white blood cells, they'll have no immune system, so they'll die of an infection. So you have to give them an immune system back. So in leukemia, what they do is they give someone else's stem cells. So that's if you're a donor on sort of the Anthony Nolan register, if you're ever called up, what will happen is they will collect your stem cells, which is done. They don't need to drill into your bone marrow. It's done all peripherally, sort of in the same way as putting a drip in and hooking you up to a machine. But they collect the stem cells, they put someone's stem cells after the chemo into the patient, and then those stem cells grow into a new immune system for the patient. So not only does the patient get the chemotherapy to get rid of the leukemia, they then have these other cells that will recognize the leukemia as foreign because they're not from themselves anymore, and they grow someone else's immune system, which has an effect in kind of keeping the leukemia away. So whereas in myeloma, you do something similar, but you use the patient's own stem cells because myeloma is not curable. You know it's going to come back, but this still allows you to use a bigger dose of chemotherapy to keep it away for longer. And survival in myeloma, just to mention briefly, because I know it sounds like a long time ago, but I was at medical school from 2005 to 2011. And in 2005, survival in myeloma was awful. People had almost no chemotherapy. They generally died within a year or two. Whereas now, for stage 1 myeloma, 80% of patients survive more than 5 years. And even this is now conservative. The kind of new treatments that are coming out, even for the older patients, the average the average progression-free survival of first choice chemotherapy, which means how long it will work before they relapse, is now up to kind of 6 to 8 years, even for the kind of older patients. So the prognosis and the survival is getting much, much better. Just in terms of other topical points while we're on it, so assisted dying is something to look up as well, something that will be very relevant for interviews. MPs did vote in favour of proposals to legalise this. It's got very specific requirements, so it's only for patients. It's not approved yet, so it's still being going through the process, but it's for patients who are over 18 who are expected to die within 6 months, and there's various negotiations going on as to exactly what the safeguards around that will be, exactly how it be approved. There's pros and cons. There's certainly pros in terms of patient choice, but there's certainly cons as well in terms of coercion. Is one of the main ones. I think it's very difficult to deal with coercion and to know when coercion is happening as a doctor. A lot of cancer patients will come to clinic with lots and lots of relatives. Sometimes they'll have like 3 or 4 children there, and their children will be, adult children. But it's very difficult to know what's come from the patient and what's come from the children with some decisions sometimes. So I think it will be a very tricky area to navigate. So just coming on to the final case then. So just something on the non-cancer side. So this is one of the common things that we see as haematologists. So this is a 32-year-old female coming to A&E with pain in the legs and back and a history of similar presentations. And the patient's sister also has similar. So it's going to be something genetic. And when we look at the blood film in this patient, so when we look down the microscope, instead of seeing nice round red blood cells, which is what you see in the top right, so the sort of background red cells are the red ones, you can see on the bottom right, some of them red, although they don't all look quite as circular and uniform as the ones at the top. But you've also got these kind of elongated boat-shaped cells, and those are sickle cells. And essentially, it's a gene mutation, so it's an amino acid substitution, which for patients will lead to these abnormally shaped cells, which can get stuck in small blood vessels. And when you get stuck in a blood vessel, whatever that blood vessel supplying, like an area of bone or something, you deny that area of oxygen, and then you get very intense pain. So patients with sickle cell disease can present with pain crises and can need very strong painkillers and good hydration to help resolve the crisis. Sometimes you can get essentially sickling in the lungs. So you block small vessels in the lungs, and that can cause something called a chest crisis, which can be life-threatening. And the way that you treat this, if it becomes a chest crisis, would be to do an exchange transfusion. So essentially what you're trying to do is take away the person's blood and put in new blood that doesn't have sickle cell to replace as much of their blood as possible with normal red cells, not sickle red cells, to stop the process essentially and reverse the process. And what you're aiming for generally is to make the person's blood less than 30% sickle once you've done the exchange. So that could take 8 units, 10 units of blood, depending on how big the patient is, really. So that's some sort of essentially one of the reasons why blood transfusion is so important and blood donation is so important, because one sickle cell patient requiring one exchange transfusion for a chest crisis will already be 8 or 10 donations. So it's quite transfusion heavy. And the role of the haematologist here is often not only to manage the patient and advise on pain control, but also to facilitate the red cell exchange. Sometimes if you're at a place that does not have the machines for red cell exchange, it can end up being a manual red cell exchange, which takes, all night essentially, and you stand there and you put the blood in, you take the blood out. But there are machines that do that, and most centres will now have access to the machines. So this is particularly topical. I know it sounds like quite a long time ago, 2021, there was a report released called No One's Listening about the lack of awareness of sickle cell by healthcare professionals and how essentially patients with sickle cell were often treated in a substandard way. So despite the fact this report was sort of 4 or 5 years ago, it's still very topical. There's still lots of cases in the press regarding it, and it's still something that really requires improvement, both in terms of care, but also knowledge amongst healthcare professionals. So it's also something very topical. So, excuse me. So moving on from cases. So if we just look at the pathway of kind of how you become a haematologist or anything else. So when you graduate medical school, you do something called your foundation years, which is a 2-year program that everyone has to do. You do a variety of specialties. It varies where you are, but normally it's 4-month jobs. So you'll do 6 4-month jobs and you'll get exposure to a bit of everything. So, it could be GP, A&E, orthopedics, haematology. So you can, within reason, you can choose the things that interest you, but obviously the foundation program is now much more random than it used to be. So there's no guarantees really of getting the area you want, which is certainly something to consider when you become a doctor, that you have to have the flexibility really for most people to, if they have to move anywhere in the country for those foundation jobs. After your foundation years, you then can apply for one of these yellow boxes. So depending what you want to do. And at this stage of the application process, whilst competitive becomes less random, and there are key criteria that you can look at well in advance that will determine who gets an interview. And essentially, if you want to do any medical specialty, so that could be haematology, but it could be respiratory, cardiology, gastro, anything where you're not doing surgery in the medical field, you would go into something called IMT, which is 2 to 3 years of training. And then after you complete that, you can apply for your specific specialty, so cardiology or respiratory, and that would then be a 5-year training program. So you've got two different points where you have to apply. So you apply after foundation, you apply again after internal medicine training, and it's the same for core surgical. GP training is what we call more run through. So if you want to be a GP or you want to do something called run through training, so run through training are specialties where you apply after F2, and if you or you apply during F2, but to start after F2, and if you get in, that's that. So you're sort of, as long as you continue on the pathway, as long as you pass all your assessments as you go, you're essentially not going to have to apply again for training, and you can become a consultant. So if you want to do pediatrics or gynecology, you start after F2, and it goes all the way through without reapplying, and you can become a consultant at the end of it, which is different to kind of most of the medical and surgical specialties. So why haematology? So I think the medicine in haematology is very interesting. It's very varied in what you do. You spend a bit of time in the lab, you've got some procedures, you see patients. There's lots of good patient continuity. So some people don't like that, some people do. But because the patients have a lot of the time cancers that are incurable, but that they will live with for many, many years, like myeloma, you end up seeing the same patients over, perhaps a decade, and often you're seeing them every 4 weeks or every 8 weeks if they're on chemotherapy. So you do get to know your patients very well, which I quite like. Compared to other specialties, for example, a surgical specialty like orthopedics, where it might be that you see the patient, you do the surgery, and then that's that. So it just depends kind of, it's personal preference there. There's lots of MDT team working in hematology, so you do spend a lot of time, liaising with psychologists, physios, other members of the team. So you've got quite a wide team in hematology. Anything to do with cancer care, there's going to be a lot of different people involved. There's opportunities for a good work-life balance. So one thing that really I think does attract people to hematology is that during your registrar years, so this is after you've done your 2 foundation years and after you've done your core medical training, usually, but not always, most hospitals, the haematology registrar does their on-call from home. So you essentially do your day shift, you go home at 5 o'clock or whatever, and when you get home, you can be called. And if things happen, like we just saw, like a new leukemia or a sickle cell patient with chest crisis, you may have to drive back to the hospital and deal with it. But if nothing like that happens, you just give advice overnight on the phone. You don't physically have to be in the hospital. And that can be throughout your 5 years of registrar training. Whereas for other specialties, the medical specialties like cardiology, respiratory, for those specialties, you're on site as a registrar, so until consultant years. And given that most people don't make consultant until, it can be 35, it can be 40, depending on the path you take, whether you're less than full time, whether you have parental leave, whether you do research, all different things. And, family commitments and different things can change as you get older. So the work-life balance, whether you're having to do on-site nights, is certainly something to consider. Downsides of hematology, so it's very different depending where you work. So it's very different if you're sort of taking queries in a district general about kind of, a lot of them will be about blood clotting, versus being in a
Yeah.
specialist centre where you're only doing myeloma. Oh, can everyone hear all right?
Yeah, I can hear all good.
Yeah.
I think somebody
Okay.
had their mic on accidentally.
Oh, fun. Okay. So very different depending where you work. I think the emotional aspects need to be considered as well. So dealing with cancer patients, breaking bad news day in, day out, telling people they've got cancer, is quite emotionally draining. And I think we do, as hematologists, to some degree, get a bit sort of used to it. And I kind of only really saw this when I was a senior registrar. I did a placement in pediatric hematology, which I did find a lot more emotional because it is just different when it's children as opposed to adults. But I was mainly working with pediatricians as opposed to hematologists, and they're not used to seeing their patients die. I mean, most patients in pediatrics, unless they have, the average patient that they see is not really at risk risk of death. They see patients with into the haematology patient, and it was very different. And I think that's when it kind of hit me a bit more, and actually the trust put on sort of psychology sessions when I was on pediatrics, which actually were really useful. But yes, you do get used to it to an extent, but it is quite an emotionally draining specialty from that perspective. So you have to kind of be okay with that, which can be very difficult. Unique communication skills. So, as I say, you spend a lot of time with patients. There's good news stories as well, but there are bad news stories, and you have to have good communication skills. You have to have good rapport with these patients, because if you don't, then it just doesn't work. It's not a one-off consultation. You're seeing these patients sometimes for decades. The other sort of downside is exams. So for all the medical specialties, you have to do something called the MRCP exams, which are a member of the Royal College of Physicians, which is 3 different exams. But for haematology, once you get into that, you have to do FRC path exams, which are some extra pathology exams, which if you were doing other specialties, you may not have that many exams. So it does have more exams, and the exams are very costly. The last exam in haematology is a 3-day exam, and you get sent anywhere in the country. So I live in London, but I got sent to Leicester for that 3-day exam. You have to pay for your own accommodation. You have to pay for the exam. So, particularly if it takes you a few times to pass, it can be very costly. Then just moving on to haematology. So just as an idea, this is the sort of rota that our haematology registrars work. So essentially, this is an 8-week period, and you can see in an 8-week period, they're going to do 1 weekend of days and 1 weekend of nights. So it averages 1 weekend every 4 weeks. However, I would say the weekend of nights in haematology, because you're doing your nights from home, and often, when you do the nights from home, you do tend to get 5-6 hours sleep at least. So you still kind of get your weekend, you're just more tired. It's only really 1 in 8 where you're actually in the hospital. And you can see that to compensate for the weekends, there are a couple of, so there's 3 0 days. So when you do a weekend, you get 1 day off the week before and 2 days off the week after. And then 1 day a week in weeks 5 to 8. They're doing 1 night shift per week. So they'll do their normal day, then they'll do the night from home. And then the next day, they'll have a half day because they'll have been more tired that day. If it's been a really bad night where the person has been in, during the night because there's been a new leukemia or whatever, they don't come in for the half day. So it tends to be a reasonable rota compared to a lot of specialties. So moving on then to sort of my journey in medical school. So I think to some extent I did what not to do. But so when I was at school, I did the usual things that people do when they want to get into medical school. So I volunteered at a primary school at lunchtime, which was one thing. And I also volunteered at a nursing home after school 1 day a week. When I was looking to get into medical school, which was in the early 2000s, work experience was much easier to get, to be honest, than it is now. I went with my grandma to an ophthalmology appointment of hers and just asked the consultant. He was like, "Yeah, that's fine." He just gave me his phone number, and I just texted him, and he arranged it. So it was much easier than it is these days. But so I think back then, work experience was kind of expected, and most people had 2 or 3 weeks. I know now it's a lot harder to come by. So I did those things when I was at school. I think now applying for medical school is much more tactical than it used to be, and I probably wasn't tactical enough. So I very much at the time was thinking, where do I want to live in the country? I think one thing that is worth thinking about when you apply for medical school is that you will be there for longer than your peers. So when everyone else finishes their degree after 3 years, you'll be there for at least 2 years after a lot of your friends leave. So you have to think about the place as well. You will have obviously the other medics who are still there. I didn't do enough research into medical school. I just applied. I thought Birmingham and London sounded like good choices as big cities, and I ended up applying for Edinburgh and Oxford as well. I think when I applied, they had the BMAT, but they didn't have, very few universities had this entrance exam. Only a few had the BMAT. So it's different now because obviously so much is on the score, and you have to be quite tactical looking at what scores are required in different places and what do they take into account. So it is different now, to be honest, in terms of the strategy. Luckily, for me, things worked out well. I didn't get into Edinburgh, I didn't get into Oxford, but then I got UCL and Birmingham at the end, so I ended up going to UCL. So at medical school, so I think one thing to mention at medical school, as it won't be too far off, hopefully for some of you, is that there's obviously lots of societies that you can join, and it's good, very good to, from a social perspective, to do different societies. I did St John Ambulance. I did this telephone listening support charity called Nightline, and I did an intercalation, which we'll talk about in a minute as well. So there are lots and lots of things you can do at medical school. I think social media is awful for this because I think when you look on, TikTok and different things like that, you see these people who are like they're doing running, then they're going to the gym, then doing this society, and it makes it look like everyone does that, all that you need to do it. So I think the key thing here is that even though I found the societies valuable and it is a good thing to do, nothing that I did as a society at medical school made any difference to my career after that point. It doesn't help you get a job generally. Um, you'll get your foundation job when you finish medical school, and your applications after that will not in any way depend on whether you're on the rugby team or whether you did St John Ambulance. So, whilst there is a lot of opportunity and it's good to engage in those things, there shouldn't be any pressure to feel you have to for any reason because it will not impact your job at all. Um, some universities have an opportunity to intercalate, others have compulsory intercalation. So UCL is compulsory. So intercalation is where, in addition to your 5 years of medical school, you do a sixth year of something you're interested in. At UCL, you could choose at what stage you did it, whereas some universities like Imperial, it's always the fourth year, I think. So you can choose different things. I did psychology mainly because I just wanted a year of doing something that wasn't medicine, and that was more close to what my kind of non-medic friends were doing. And in terms of hours in the week, you suddenly go down from doing like a 9 to 5 to like 8, 9 hours a week. And it was a good year from that perspective. Obviously, there's impact for student loans and things like that, though. But there's lots of things you can do, and sometimes you can do something totally different. So I think if, for example, you decide medicine is not for you and you didn't know that till you got to medical school, you can actually, if you intercalate in your third year, after that, you can actually leave with a degree. So if you do 2 years of medical school and a year of psychology, you would get a degree in medical sciences with psychology, which is treated as like a science BSc. And then if you want, you can leave medical school at that stage. I did have a friend who really didn't think it was for her, and she did that. Imperial have like a finance intercalated BSc, so she did finance, then did medical sciences with finance as a BSc, and just left and got a job in the city in finance. So it is an opportunity if you decide medicine's not for you to not have to do a whole new degree again. It's also an opportunity to potentially get involved in research. It gives you a path into research that if you are that way inclined and you want to do that, that you may not get as easily just through going through medical school without. It does give you some advantages when you apply for jobs afterwards. They do in some applications take it into account. So it can give you points. But equally, if it's not compulsory in your medical school and you don't want to do it, most people haven't done it. So it's not something I would feel pressured into doing either. So for me, I went to UCL. I did my foundation training in North London. I was a bit boring. I stayed in North London for everything. So I did my core medical training in North London. I did my haematology training in North London. Um, during my haematology training, so during my 5 years, I took 2 years out to do a research degree, which was also at UCL. That I really enjoyed. It was a different pace, and also again lots of research skills, lots of ability to kind of evaluate papers, write papers, and it's really helped me as a consultant actually to be able to do more research. So I think research degrees, if you want to do them, are very good. They're certainly not compulsory. It's very specialty to specialty. There's some specialties where people, most people do a research degree, and there's others where almost no one does. So it's very variable. Things are a bit different now in that for foundation training, you get preferences, but you can be placed around the country a bit more than we could. So that was kind of my path. In terms of the pros and cons then of being a doctor and applying to medical school in the first place. So I think there's lots of pros. I think there's a huge variety of career options. You can end up going into medicine and being in public health. You can be a GP, you can be a hospital consultant, you can end up doing a hospital specialty where you're a surgeon and doing operations. You can end up doing something where you're a histopathologist and you don't even see patients anymore. So, you don't have to know exactly what you want to do when you start medical school, because there's a huge variety of things you can do, which are all very, very different. So even though it feels like pigeonholing yourself. You're really not. And the other thing is, if medicine isn't for you, there are other job opportunities which a medical degree is seen as a good thing for. Sorry, I just don't know if we can mute. I think someone's. Yeah. Okay. All right. So in terms of other pros, so I think work life is interesting. I really like the fact that I'm not sat at a desk all day. You can, walk around the wards, walk to the lab, you're doing your clinic. I think the day just goes much, much quicker. I never really have to clock watch at work. The day, if anything, goes too fast. And so I actually really value that. I can't imagine myself sitting at a desk all day. I mean, I didn't particularly enjoy being in the library all day revising, as you obviously have to at medical school. So I think the variety of being able to walk around and do different things with your day and constantly move from one thing to the next is really good. Um, Treating patients is the other thing. So not only kind of, people are obviously very grateful. You develop a great rapport with patients. It's very rewarding as a job. And whilst the hours can be long, it's very predictable hours. So I've got friends who do all sorts of different things, but lots of my friends, particularly lawyers, actually, they don't know when they're going to be able to leave work. That often they can't make dinner plans. They don't know if they'll be able to leave. They'll end up working till some stupid time sometimes. If you're working a long shift in medicine until 8, generally you're going to leave, you might leave a bit late, but you're not going to leave ridiculously late. If you're supposed to finish at 5, you're not going to be there at 10. So there is a predictability to the longer hours, which does let you plan your life to some extent. There are issues around that as well, but certainly at consultant level, sort of planning your life becomes much, much easier. And it does feel a long way off, but I think what people have to remember is whilst you're going to be a resident doctor for at least a decade in most cases, if you are going to medical school at 18, 19, 20, you're going to finish medical school around your mid-20s, you're going to become a consultant until your mid-30s. You've then got over 30 years as a consultant. So looking at what kind of people do as an F1 or an F2 is really not what you should be looking at. Yes, if it's completely off-putting and you can't do it, fine, but it's a year of their life or 2 years of their life, whereas consultant is 30 plus years. So I think to some extent, as much as it's a long slog to get there, looking at the consultant life is really what you need to consider when you think, is this actually what I want to do for the rest of my life or not? Cons, so obviously work-life balance. Some of the kind of rotas, particularly when you're in your first couple of years, can be really awful. It can be something like 1 in 2 weekends, 1 in 3 weekends, which really is difficult. I think I don't know anyone who's not missed people's weddings and missed all sorts of life events because of awful rota patterns. And as a result of that, stress and burnout is very common, particularly in the first few years. The system is under-resourced. So often there's not enough people on the ground, depending where you work. Often you're very busy, often you're very stretched. And then, as I'm sure most of you know about student debt, so sort of Plan 2 student loans and the accumulation of debt that goes up and up afterwards is obviously a massive negative because you're spending more years at university than you would if you were doing a shorter degree. The other thing to think about is staying in one place or not. As I've said, yes, you don't always have complete control over this, but whether you stay for your jobs where you've been to medical school, whether you work near home, I mean, it's very challenging being a doctor. So some people do like having family support and think, actually, if I go to medical school in the city I'm from, then at least when I'm having to do crazy hours in the library, at least when I'm meeting patients who have a terminal prognosis for the first time, you've got your family, you've got your support systems. So there are pros of staying in one place, sort of the familiarity, things like that. I think as well, obviously the non-work life, if that's the area your friends are in, you may have friends who aren't going to university who are going to still be in that area. You may have friends who, after university, go back to that area. So for your kind of latter years of medical school, they'll be there. The other thing is where if you stay where you went to medical school, it is easy to build your portfolio. So, for example, when you get a job as a doctor and you then have to apply for kind of your core medical or core surgical or GP training. You've got the first 2 years working before you start that, and you apply for your job about a year and a half in. And essentially, what they look at for those job applications is has this person done audits? Has this person done teaching? all those sort of things. And I was lucky in that I did my F1 year at somewhere I'd been to medical school. I knew the people, I knew who ran the teaching. It was much easier for me to just say, okay, well, I know I need to do this level of teaching to get all the points for my application. And I know here who runs the teaching, and it just made things easier to kind of get the points you needed. So there are definite pros to kind of being for uni in an area you're familiar with. There's obviously and for being a doctor afterwards. There's obviously cons as well. So being in one place and not moving around too much, you get a lack of experience of all the different types of hospitals. You know, things aren't necessarily the same in London as they are somewhere more rural or in major cities. Um, the other con of staying in the same place is that you may want a kind of different university experience. You may want to leave where you've been. And if you stay in one place all the way through, once you're qualified, then there is the concern as well that if you've worked for a consultant as a kind of F1, F2 and got worked up, by the time you're a consultant, you're not necessarily always seen as an equal because they remember you as being their student or their junior. So sometimes it is good to move around and then you come in and it's like that group of people has only ever known you as a registrar, only ever known you as a doctor, or only ever known you as a consultant, which can be better in some ways. So my current job, just in terms of what consultants do all day. So now I work 1 in 6 weekends, but it's not the same as when you're more junior. So as a resident doctor, when you do the weekend, you're going to be doing like 9 a.m. to 9 p.m. As a consultant, my job plan is that I only have to be in the hospital for 3 or 4 hours per day at weekends. So you kind of go and you see the new patients, the complex patients. You liaise with the resident doctors, check if they need help with anything. But your weekends are not all day. It's not got the same impact on your life. I do a lymphoma clinic, a myeloma clinic, and an amyloid clinic. So amyloid, this type is called AL amyloid, which is essentially when people who have myeloma or similar to myeloma, those patients, some of them start producing a protein that can damage their organs, and that's what amyloid is. So I do an amyloid clinic as well. So my post is split across 2 different hospitals. One hospital is the National Amyloidosis Centre at the Royal Free. And then for my lymphoma and myeloma, I'm not there. Separate to this, so about half my week is kind of split between those clinics and kind of on calls and multidisciplinary team meetings. And then about half my week is kind of other stuff, so research and clinical trials. So I lead on a couple of clinical trials. I'm a college tutor, which means that I look after the resident doctors in my department. So I do all the rota stuff, the pastoral stuff as well. And I'm also the training program director for Imperial and Northwest London for haematology, which means I'm in charge of kind of all the registrar placements across Northwest London as well. So that's kind of just another example of, when you're a doctor, as a consultant, some people will focus their job plan more on kind of all medicine. Some people go into kind of leadership, management, teaching. So again, as a consultant, there is an opportunity to kind of branch out to other things, which is good. So in terms of day in a life, so kind of as I've said, so I do 3 clinics a week. I have an afternoon where I'm in a multidisciplinary team meeting. I've got my teaching and research roles. For me is about half a day a week. And then all consultants get something called SPA time, which tends to be about 1.5 to 1, about half to 1 day a week, where you essentially have time to dedicated time to further your own knowledge, to work on what's called portfolio requirements. So we have to revalidate with the General Medical Council every 5 years. And to do that, we have to show that we've done a certain amount of continued professional development. And there's other criteria, but we get time every week to work on that as well. And your individual job plan is something that you essentially, when you get the job, negotiate with the hospital that you're working at, depending on what they need from you and what sort of career you want. And you generally would have talked to them before you applied anyway, so it shouldn't be a surprise. So I think that's about 45 minutes. So we'll stop there and then we can see if anyone's got any questions at all.
If anyone pops any questions in the chat, I can read them out. So if you want to put your mic on, that's fine. You can pop it in the chat. So someone's asked, is it difficult to go from F2 to resident doctor?
So, so firstly, resident doctor will refer to any junior. It used to be junior doctor, now it's resident doctor. So technically, an F2 is a resident doctor. We don't have the same terminology here as in America, where you'd be an intern then a resident. But in terms of F2 to resident, in terms of F2 to like core trainee, we'd call it here. So you know, to go from to core medicine, core surgery, something like that. Yes and no. I think the competition rates on paper are, you know, very difficult. Lots of people don't get the job they want. The UK prioritization is coming through. So actually, if you've trained in the UK, you're going to be prioritized for those jobs. So things may get a bit better in the future. Um, I think it depends. I think people who are very switched on, people who, when they start their F1, have already looked at the application scores for core medicine and core surgery, and who know this is what I need to do for teaching, this is what I need to do for audit. Essentially, you can guarantee yourself an interview. Like if you look at what the interview requires, everyone has the opportunity to get an interview if they're switched on early enough. Obviously, when you start your doctor job, it's overwhelming. You're not necessarily going to straight away on your first few weeks, the doctor be able to say, okay, right, what teaching do I need to do for my job application in a year and a half? But you can pretty much be sure of an interview if you do all the right things. It is very competitive. The competition ratios are very difficult and it depends what you want to do. I mean, the competition ratios for things like cardiothoracic surgery are absolutely awful. It's something like 30 applicants to one place, whereas for other things, then they're nothing like that. So yes, it's difficult, but it's certainly not impossible. And to give you an idea, and you know, it is a controversial area in that there's a lot of doctors talking about this on social media, and I'm not saying it's easy. But for example, I have actually just put out an advert for a trust grade job in my hospital, which means it's the equivalent of an F3 job. So it's for people who finished F2 and they haven't applied for a resident training program, but they want to work as a doctor in a hospital for a year on a fixed contract. And essentially, if you didn't get into training and you want to do that year, that will sort of put you in a really good position for the next year because you've got a whole year to kind of work on, you know, things for your application, things like that. And I had 70-ish applicants for that job, which sounds quite overwhelming, but actually not a single one of the 70 applicants went to a university in the UK, which doesn't mean they were bad at all, but very few of them had UK experience. So, you know, only about 5 of them had actually worked in the UK before. So if you're someone who has worked in the UK before, it's going to be easier for you to fill in the application, you know, and answer the questions because there's going to be some questions that might be on, you know, instant reporting, and there's quite specific things in the UK. So I do think if you're UK trained, you'll find it easier to score well in those interviews. So there are jobs out there, even if you don't get into training straight away, there are ways around it. And actually, of this particular job, so I've been in this post for 5 years, and apart from one person because they didn't want to, every single person we've had in that post we've supported and has got into training the next year. No one has been in that post without getting into training longer than 12 months, and most of them have actually been in the post 6 months and got into training and then left. So it is hard, but it's not impossible. Um, Going down, so I think the next question is, do I think I've got a good work-life balance? So I think I do. I'm, you know, I sort of work in terms of my week. So I have one day at one hospital and the other 4 days at another hospital. I'm allowed to work from home one day a week, which is kind of my admin day and my SPA day where I do CPD and stuff. So, you know, when you on the day you work from home, you can kind of drop your kids at school. It's, you know, you've got a better work-life balance in that sense. My job is very much Monday to Friday, 9 to 5, apart from when I'm on call. And that 1 week in 6, when I'm on call, I can be called during the night. I can be, you know, I have to go in for a few hours each day at the weekend. But apart from that 1 week in 6, it's very much a 9 to 5 job. And if you look at the salary we earn as consultants and you try and find another job for the same salary that's very 9 to 5 in that way, you don't necessarily find it very easily. So I think as a consultant, I've got a very good work-life balance. I think at times when I was training, I had a terrible work-life balance. When I did intensive care, the job was absolutely awful. We did like 7 long nights in a row. I was tired all the time, couldn't see anyone because you're just not in the mood. So you go through periods where you have a terrible work-life balance, but I think end result is a good life balance. How would you suggest to get work experience for under 16s? Because there's a lot of rejection because the requirements being 18 plus. I think under 16 is going to be very difficult. I think 16 to 18, you know, when you're in sixth form, there's more of a chance. So some hospitals have a specific work experience program. often now you can only get the work experience if you live in the area of that particular hospital because it stops people just giving it to people they know. So, I don't know if anyone here is London or not, but it's just because that's where I know. But for example, the Whittington has an excellent work experience program that you can kind of Google on their website and apply for, but I think you have to be local to the Whittington. So I think going into GP surgeries in your area and just asking to see if there's anything you can do is one thing. I think, Googling all your local hospitals, whether they've got work experience programs is another. But I think the other thing is, don't only focus on traditional work experience. There's also other types of work experience. You can get a job in a kind of administrative role in a GP surgery, or, you can get a job as a healthcare assistant in a nursing home. And those jobs are seen as, just as valuable. You don't expect on a medical application people to have had work experience. Different people come from different backgrounds, have different opportunities. It's great if you can get it, but it's not compulsory anymore. So just think, how can you gain insight into what doctors do, and how can you convey that on your personal statement, and how can you show commitment? It doesn't have to be work experience, because yes, the age requirement is often 18 plus, and it isn't easy. But I think under 16 it will be very difficult. But I think 16 to 17 there are some work experience programs. Um, how much time in lab compared to clinic? So for me, mine's my lab. So I'm on a rota where we cover the lab one day in every 11 days. And as a consultant, I'm rated for the lab on the day I do lab for 2 hours. So I'm literally doing 2 hours every other week. So very little time really. Some people, if you're some, there are hematologists who have 50% lab usually in big centers. You could have a job that's 50% clinical, 50% lab, but it's very much dependent on the job and where you apply. Um, and then what a registrar is. So generally, a registrar refers to someone who so you do 2 years as a foundation doctor, and then when you start your core or specialist training, your first 2 years, you'll be what's called an ST1 or a CT1, and then a CT2 or an ST2. And during those years where you're an F2, CT1, CT2, so your second, third, and fourth year as a doctor, you'll be called an SHO often under the old terminology, which is senior house officer. But once you've been a doctor for 4 years and you start your fifth year, and then your kind of role will be something like ST3 or CT3. Once it's a three, that's when you're a registrar. And in medical specialties, it tends to be when you're working in a specific specialty. So when you're a cardiology registrar, it will be it's slightly different now, actually. But in hematology, when you apply for your first job, when you start hematology training, you're an ST3, and that's when you're a registrar, and you're a registrar then for 5 years, and then you're a consultant. But you have to sort of jump through various hoops during the 5 years. You have to tick all the boxes, pass the right exams, and you get signed off each year to get to that point. It's slightly different now because in core medicine, it used to be 2 years. They've made it 3 years. And in your third year, you're considered a registrar. So in general, it's the sort of fifth year of work. As long as you progress every year, it's your fifth year as working as a doctor if you haven't had any career breaks and things like that. Um, do you redo the year if you don't pass the exam? Oh, sorry, I missed one. Okay, sorry, I missed one. So what else can you do for applying for medicine to make your application stronger other than volunteering? I think it's all about sort of commitment to knowing what medicine is about. I think it's not only about experience of the NHS, experience of what being a doctor is like, but also showing that you have the right skills. The reason people are volunteering generally is because it shows that they have the right skills to become a doctor. I think in terms of other sort of outside the box things you can do, um, some people I know volunteered to be pretend patients for medical school exams to see what the exams were like. Some people went on specific communication skills courses for sort of complex communication so that they could show they developed that skill. I think any sort of job, anything related to healthcare, obviously volunteering is the obvious one. I think also other things that are completely outside the box, just a society where, if you're sporty and you're on the first team for rugby, and you've shown determination, you've shown that you excelled in your academic work despite fitting in, your rugby, which may have had demands and etc. etc. I think showing that you can multitask, showing that you kind of can excel in different areas and that you can essentially manage your time, prioritize your time, they're all important things for being a doctor. So they really just want, different universities slightly different, but well-rounded people who've shown that they've got the right skills and the right sort of attitudes, the right background. So volunteering is a good way to show that, certainly. But there's lots of other things you can do as well. And it's the commitment specialty is probably the most important because I think with the way the NHS is now, not everything's perfect, and they want to see that you have the insight to know that it's not all going to be perfect and that there are going to be challenges, and you know what those challenges are, and that you can show from experience why you know what they are. Do you redo the year if you don't pass the exam? So it depends if you mean at medical school or as a doctor. So at medical school, it depends. Different medical schools have different policies. Some people redo a year as a doctor. So as a doctor, it's all a bit cutthroat actually. So in haematology training, you get 4 chances to pass each exam. If you were to take it 4 times and fail, you would be kicked out of training because there's nothing you can do. It's not. It's a sort of exam board separate that only allow 4 attempts. So if you haven't passed 4 times, there may be extenuating circumstances. There are people who may have been, diagnosed with ADHD, and then adjustments may have been put in place for them, so they may get an extra attempt. But generally, if you fail the maximum number of times, then you will be kicked out of training, and that will be that for you in that specialty. If you do not pass the exam in time, so in haematology, you have to have passed the first exam by the end of your 3rd year. So if you've only taken the exam twice, but you've not passed by the end of your 3rd year, then they will extend your training and give you more time, and they can extend by up to 2 years. So it's not something I'd be overly scared about in the sense that it's very rare. So I know of a couple of people who haven't passed their exam and therefore have ended up not finishing their training. Those people generally are now working in kind of long-term senior registrar roles that are not in training. So they're still a doctor, they're still, earning a good salary, but they're not consultants. But it certainly accounts for only a couple of percent of people who get into, I can only talk about haematology because that's what I know, but it will be certainly less than 5% of people who get into haematology training. So if you've managed to get to haematology training, you've already passed your medical school exam, you've already passed the member of the Royal College of Physician exams. So it would be very unusual to then fail these exams. And if you pass MRCP, generally you can do it. And actually, the people that I know who have struggled with the exams and haven't got it through training are actually people who never did MRCP because they've trained abroad and they've had an equivalent exam, so they haven't had to do it in the same way, or they've not done it in this country. So I think if you've passed MRCP in this country, you're in a very good place to get through the exams. Advice on how to do well in MMI interviews. So I haven't done medical school interviews for years. I do more like registrar interviews now, but generally with all of the interviews where you're kind of put in a situation and if it's like a role play station or you've got an actor or something like that, the general thing is that they're not generally going to, certainly at this level, they're not going to expect lots of knowledge. It's going to be about sort of common sense and the skills that they're looking for. So I had an example where we had this applicant who was applying, and the station was that this woman has come in and she's very anxious because she's read an article that too much caffeine, sorry, that if you have loads and loads of caffeine, it reduces your risk of Alzheimer's, dementia. And her mother had Alzheimer's, so she's very worried. And she brings you this article, and it clearly says that if you give the equivalent of like 20 cups of coffee a day to mice, these mice had a lower risk of dementia. I don't know if they made up this thing for the exam. I'm sure it's not a real paper, but this person looked at, spoke to the patient and then just went, "But are you a mouse?" And I don't think he meant it in a bad way, but it just came across really awful from a kind of compassion point of view. So I think practicing lots with friends, all different scenarios that can come up, to give yourself a better chance of sort of staying calm under pressure, being used to the type of thing that will come up, is helpful. But I don't have a huge amount of experience of kind of medical school MMI interviews, so can't comment too much more on that.
Okay, perfect. Thank you so much. That was really helpful. And some really interesting questions and answers there. We're going to go onto the breakout rooms now. We should have two volunteers with us in the audience. So I'll create two breakout rooms, and if the volunteers could go into one each, um, that will be brilliant. Probably that's a really good point to ask. If you have any questions about MMI interviews, anything like that, because our med students have done them in the last couple of years. So they'll have some good advice as well. But the advice Oliver gave was really, really good as well. I'll just go make the breakout rooms now. So everybody should be going into them, and I'll open the rooms. Hello, is there a volunteer in this room?
Hi, yes, it's me.
Oh, brilliant. Thank you so much. I'll just go check in the other room that they're doing okay. If you need a hand or anything, just shout and I'll pop back in.
Great, thank you. Hi, guys.
Hello, is there a volunteer in here? If not, that's fine. We can I can be the volunteer. Okay, that's fine. So what we're going to do is I have some practice questions, and we will I'll say the question and I can put it in the chat as well. We can just go through them together. Um, if you don't feel confident putting your mic on, that's fine. You can pop your answer in the chat. No one's going to judge. We're all here to learn and practice. So try not to worry too much about other people judging your answer or anything. So the first question is, um, what conditions do you think haematology doctors look at, or what is the role of a haematology doctor? So, what do we think based off what Dr. Cohen said in the talk? So somebody has said blood-based diseases or conditions. So yeah, brilliant. So there were some really good examples in the talk. So what were some of the diseases? Can we remember what some of them were called? Because it's really good to show specific knowledge in the interviews if they have or specific knowledge at your level, I should say. So no one's going to expect you to be at the level of a hematologist, but it's good to have some level knowledge of stuff. Yeah, so brilliant. So cancers like leukemia or myeloma, thrombosis, yeah, brilliant. So those are the key ones that he talked about. And no one's going to expect you to know specifically how to diagnose leukemia or like the diagnostic criteria for myeloma. But it's good to have an awareness at your level of what these conditions are. Um, so the next question is, are you aware of a recent scientific development that will improve patient care? So I know Dr. Cohen talked about some of them during the talk, but you may have come across some in your research or as you're preparing for interview. It's always good to keep an eye on the news, especially when you're coming up to MMIs, because they like to discuss hot topics. Again, feel free to pop it in the chat, or if you want to put your camera on, or your mic on rather. Yep, so Angel, do you want to go ahead?
I was gonna say, like recently they have introduced like patient portal where
Mhm.
you can like book your appointments online, so you don't have to like wait for like in long waiting lists.
Yeah, brilliant.
So it's yeah.
Sorry, you carry on.
No, I was just gonna say, so it's easier for patients to like not feel that they have to wait for too long and just like book appointments and yeah, whenever they need.
Yeah, that's a really good idea. So that definitely has a lot of positives, doesn't it? Because patients can do it conveniently at work. You don't have to wait in the queue to call the GP because we all know that's a bit of a nightmare. But can you think of some downsides of that? Because it's good to give a balance view, isn't it? So what do you think could be some downsides?
Um, I was gonna say that the downside could be that the patients, like, even if it's like a really small issue, they try and like book their appointments to, I don't know how to explain it.
That's okay. Um, so yeah, there are definitely some downsides. Maybe the elderly, they will struggle to book an appointment if they don't have a phone, or perhaps homeless people who don't have access to the internet or don't have an address to register with. That might be a challenge for them. But yeah, that was a really good balance view that you gave there, Angel. That was really good. Has anyone else seen anything in the news or anything perhaps relevant to hematology that we could talk about? Or anything from the talk that we want to discuss? What about what Dr. Cohen said about assisted dying? That's a really relevant piece of information. So that is currently going through the process of, well, legislation. What are people's opinions on that? Yeah, go ahead.
I think obviously, like, if you look in like the four through the aspect, I mean, if you consider the four like pillars of like medicine, I think I forgot the exact name, but like, I think it's like autonomy is one of them, and I always used to think that it's an important view to consider how like someone who can't speak for themselves would think of it, especially because maybe in the past people would think that, if you know the person, you'd think maybe they wouldn't want to live like this. But their opinion could have easily changed, and I feel like it isn't something which is in our hands to decide. Obviously, we should do what the law says, but personally, I think it is. It's something which is very difficult, and you don't want to feel like you're seeing so many like. I feel like personally, I find it as though like the NHS is under some strain right now. You don't want to feel as though you're making it worse by just like by kind of not putting in your input, but you also don't want to act as though you're like, doing something that someone else wouldn't want.
Yeah, I think you raised some really good points there. So, definitely with how stressed the NHS is, some people may think, oh, I'm just doing them a favor if I have an assisted death. They might feel like a burden to their family. They might feel that, you know what, for whatever reason, I do want to end my life. And maybe that's not for the right reasons. So there's definitely issues around coercion and consent and informed consent as well. Um, and I really like that you brought up the pillars of medical ethics. I think when we're answering ethical questions in an interview, it's really easy to just discuss our personal opinion. Um, and everyone has their own opinion, which is they're entitled to. I have my opinion on it. I think I'd lean more towards being in favour of assisted dying, with the proper safeguards and support in place. Um, I think in interview though, it's more important to focus on applying the ethical principles. So I really liked how you started out with talking about the medical ethical pillar of autonomy. Um, I'd really suggest for trying to focus on basing your answers around that. So you could say, on one hand, the ethical pillar of autonomy supports assisted dying. However, the other ethical principle, so you could say the issues around informed consent, that could be a challenge to the act, and that could be a downside. So try and base it on the ethical principles rather than your personal opinion, if that makes sense. Not to say that we're not entitled to our own opinions, everybody is. But in interviews, it's best just to focus on the ethical side of things because that's where you're demonstrating your understanding and your ability. And that's what will distinguish you from people who might just say, I think it's wrong or I think it's right, if that makes any sense.
Yeah, it does. I think that's definitely important. I could take that on board.
Yeah, brilliant. But it was a really good answer, and thank you for contributing. It's really, really brilliant. So another ethical question then could be if you had a patient who is a Jehovah Witness and they require a blood transfusion, but they're refusing this treatment, how would you approach this? And you might think this is a bit far-fetched, but we actually have had a couple of patients who are admitted to surgical ward and who are Jehovah Witnesses. So how would you approach this? So let's say, for example, they were in a situation where they were having a bleed, and it was a life-threatening bleed where if they didn't have a blood transfusion, they were risking their life. So how would you approach this situation?
I was gonna say that I think first it would be like good to understand that why they're refusing,
Mhm.
and like look at like if there are any like religious beliefs or like any trauma kind of thing. And if like they have actually like have the capacity to actually make the decision, like
Yeah.
if they understand the situation and they look at the risks and the benefits. So I think it's really important that we give them really like clear and honest information about what they have.
Yeah, brilliant.
And
Some really good
at the
points.
end, yeah, at the end, we'll just respect their autonomy, I think.
Yeah, definitely. So, first of all, I really liked how you structured your answer. It's really important to mention the keyword. So, autonomy is a really good keyword. Every person has the right to autonomy, and it's really good to drop the pillars of medical ethics in where you can. A really good point you raised about capacity. So, what do we know about the laws that govern capacity? What kind of things do we need to make sure a patient has in order to say they have capacity to make a decision? So if the Jehovah Witness refuses the blood, how do we know they have the capacity to make that decision?
They have to be able to retain the information that you've given them, and they also have to be able to like say it back to the doctor and then weigh the pros and cons of the information given. And then if they're below 16 and they have capacity, you've got to consider Gillet competence.
Yeah, brilliant. You hit the nail on the head there. So they need to be able to understand, retain, weigh up, and communicate the information. And as you said, if they're under 16, they can have Gillet competence, which means they can refuse treatment in certain situations if the doctor deems that they are Gillet competent. So if the first thing we need to do, I agree, is we need to understand where they're coming from and get to the bottom of why it is they're refusing the blood. Because we shouldn't just assume that every Jehovah Witness is going to refuse a blood transfusion. And maybe there are other things at play here. Maybe they had a bad experience last time. Maybe they're worried about having an allergic reaction. And maybe if we talked it through with them, they might actually consent to have the blood. So that's a really important first step. And then, yeah, I agree with Lynn. We need to get to the bottom of whether or not they have capacity. Because if they have capacity, at the end of the day, as long as we've given them all of the information, as Hafsa said in the chat, we need to give them all the information and the benefits of getting a blood transfusion, as well as the risks. So we need to give a balanced view of it. If they have autonomy, sorry, if they have capacity, we just have to say, well, we've given you the information, but you can make your choice. And they are free to make a choice, even if we wish, or we might wish it was a different choice. So yeah, that's a really important point as well to make, is that people are allowed to make unwise decisions, and just because they make an unwise decision, that doesn't mean that they don't have capacity. A lot of the times you see people making very silly decisions, but as long as they have capacity, sadly, you just have to let them do that, which can be quite frustrating actually at work. And Osag, sorry if I'm saying that wrong, has also said you need to give them all the information about not taking the blood transfusion. So yeah, we need to make sure that they know what's going to happen and the risks of not having the blood transfusion, because without that, they don't have all the information and they can't make an autonomous decision. So Jasleen said we can talk to their family member. So that's a really good suggestion. So sometimes it can help to have family in with the discussion. And one thing I would say is be really careful to mention that you'd gain consent from the person first to discuss with their family member, because otherwise you would be breaking confidentiality. The exception is with children. Obviously, you don't have to to get consent for the child to speak to the parent, but in adult patients, you'd need to ask the patient, is it okay if I speak with your wife, or is it okay if we have a discussion with your son about what's going on? And if they say no, you can't have a chat with them, unfortunately. And we had a patient recently who was end of life, and they said that we couldn't let the family know about what was happening. And that was really difficult because we couldn't tell the family, but we also had to treat the patient as an end of life patient. So stuff like this can cause some real ethical issues, in real life as well. So yeah, really good, guys. That's all the questions we have prepared. If anyone has any other questions about applying to medicine or interviews, feel free to ask now. But if not, we'll head back into the main room. And also please send in your number into the chat if you haven't already. That will be on the original email from me. Perfect. We'll go back into the main room then. Okay, I think we're all just rejoining now. I think there's a couple more coming back into the main room. Okay, I think we're all back in the main room now. If anyone has any questions, feel free to ask, but if not, we can end the talk. Thank you so much to everybody who came. We all really enjoyed the talk, and thank you to Dr. Cohen for the talk. Um, if anybody hasn't sent their numbers into the chat, please send them in now, and I can add them onto the spreadsheet. That's just for our attendance, and so we can make sure you get the certificates after the final session. We'll send out the link for the next session on emails. Keep your eye out for that. And yeah, if anyone has any questions, just feel free. So we'll get the certificates after the last session. We'll go through and see who's attended what, and then we'll send them all out. So don't worry, they are coming, but we're just sending them out after the last one. So an extracurricular activity basically is something you do outside of academics. So it could be like a sport, or like a part-time job, a club, like scouts or guides, anything like that. And then the supercurricular is something on top of a subject. So it could be doing um like a course about biology or doing an EPQ about biology. So it's kind of related to the subject, if that makes sense.